Hi everyone. Now we are going to discuss about the types of anesthesia. First, introduction of anesthesia. The use of drugs and inhalational agents that makes the patient unable to feel the pain during surgeries and it induces sedation to unconscious stage. Next, we are going to discuss about the types of anesthesia. Anesthesia is classified into general anesthesia and regional anesthesia. The regional anesthesia is classified into nerve blocks and local anesthesia. And also the nerve blocks is again divided into peripheral nerve blocks and central neuraxial blocks. The next we are going to discuss about general anesthesia. General anesthesia are the drugs which can cause reversible loss of sensation and consciousness. Classification of general anesthesia. General anesthesia is classified into two types. The first one is by the use of inhalational agents and the second one is by the use of intravenous drugs. The next we are going to discuss about the features of general anesthesia. So the features are loss of all sensation especially pain, induced sleep and amnesia, third one is immobility and muscle relaxation, and the fourth one is abolition of somatic and autonomic reflexes. Next we are going to discuss about the triad of general anesthesia. The triads are narcosis, analgesia and muscle relaxation. Next, we are going to discuss about the components of general anesthesia. The term anesthesia was given by Oliver Wendell Holmes. The basic components of general anesthesia are narcosis, analgesia, muscle relaxation. The anesthesia in present days should be balanced anesthesia, a concept laid by John Lundy in 1926. The components of balanced anesthesia are narcosis, analgesia, muscle relaxation, amnesia, abolition of reflexes, maintenance of normal hemodynamics and physiological homeostasis. The balanced anesthesia can be achieved by the combinations of different techniques such as general anesthesia with different agents, pre-medication and regional anesthesia. The next we are going to discuss about the stages of anesthesia. Stages were described by Gödel with either. However, in current anesthesia, where newer inhalational agents are so fast acting that these stages do not exist, therefore there is no need for the students to go in details of the stages. And the only silent features to be noted are the first stage is stage of analgesia. It is from analgesia to loss of consciousness. The second stage is stage of excitement. It is from the loss of consciousness to rhythmic respiration. The third one is stage of rhythmic respiration. In third stage there are four planes. They are from rhythmic respiration to cessation of eye movement. The second plane is cessation of eye movement to respiratory paralysis. The third plane is respiratory paralysis to paralysis, and the fourth one is respiratory paralysis, and the last stage is medullary paralysis. So the stage of surgical anesthesia is a stage 3, plane 3, because laryngeal reflexes goes in this stage and intubation can be performed. Onset of surgical anesthesia, stage 3 is best indicated by onset of regular respiration. First, reflex go to the eyelash, therefore loss of consciousness is tested by the absence of eyelash reflex, while the last reflex to go in cranial reflex, which is tested by touching the carina with the suction catheter, which should be initiate cuff. The next one is initial pupillary dilation seen in stage 2 is because of sympathetic stimulation. The return of reflexes is in opposite sequence, first to come in cranial reflex and the last is eyelash. Therefore, theoretically, it is cuff which should come first, but swallowing comes earlier because coughing also requires diaphragm and respiratory muscle efforts. The next we are going to discuss about regional anesthesia. In regional anesthesia, the first one is nerve blocks. Nerve blocks may be classified as central neuraxial blocks, which means spinal and epidural, and peripheral nerve blocks. Nerve blocks are given either in regional anesthesia or for acute and chronic pain relief. The next one is peripheral nerve block techniques. The conventional method of giving a nerve blocks is by electing paresthesia and or using the nerve stimulator. However, the use of ultrasound has revolutionized the practice of nerve block in modern day anesthetic practice. The next we are going to discuss about central neuraxial blocks, which is spinal and epidural anesthesia. A spinal anesthesia is also called a spinal block or subarachnoid block is the type of regional anesthesia that involves injecting a local anesthetic drug into the subarachnoid space. It is usually given between L3 and L4 vertebra. The vertebral column consists of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar and 5 fused sacral and 5 fused coccygeal. The vertebral column has 4 curves, thoracic and sacral spine and convex posteriorly while cervical and lumbar spine are convex anteriorly. Vertebral canal is bounded anteriorly by vertebral bodies and intervertebral disc laterally by pedicles, posteriorly by lamina, ligamentum flavum and roots of vertebral spines. In vertebral canal lies the spinal cord with meninges. Structures encountered during spinal anesthesia. Structures encountered while giving spinal anesthesia from posterior to anterior. They are skin, subcutaneous tissue, supraspinatus ligament, infraspinous ligament, ligamentum flavum, epidural space, dura mater, arachnoid mater, subarachnoid mater, pia mater and spinal cord. The tips of spinous process are such as epidural or spinal needle should be inserted obliquely in thoracic region and almost right in lumbar region. Surface landmarks which are important while giving spinal or epidural anesthesia are C7. The spinal process of 7th cervical vertebra is very prominent and easily palpable. The line joining the highest point of iliac crest corresponds to L4 and L5 interspace or L4 spine. It is very important to identify this intervertebral space while choosing the space for giving spinal or epidural anesthesia. The next we are going to discuss about epidural anesthesia. The epidural anesthesia is given in epidural space, which means extradural or peridural space. It lies outside the dura mater, that is between dura and ligamentum flavum. It extends from foramen magnum to sacral hiatus. Epidural anesthesia is given in this space. Epidural space is triangular in shape with apex dorsomedial. Contents of epidural space: anterior and posterior nerve roots, epidural veins, spinal arteries, lymphatics and fat. The epidural veins forms a plexus in epidural space called as plexus of Batson. These veins are very important for clinical point of view because they directly drain into inferior vena cava. Any pressure on vena cava as in pregnancy or abdominal tumors or ascites leads these veins to become engorged, pushing the dura medially, which reduces the subarachnoid space leading to higher spread of local anesthetic. The next we are going to discuss about local anesthesia. First local anesthetic used in clinical practice was cocaine by Carl Kohler for anesthetizing the cornea. Local anesthesia is defined as a technique to induce the absence of sensation, typically pain, in a specific small area of the body using special drugs called local anesthetics. The commonly used drugs for local anesthesia is lignocaine and bupivacaine. Next, we are going to discuss about the classification of local anesthesia. Local anesthesia are classified on the basis of chemical structure and duration of action. First, on the basis of chemical structure, chemically, local anesthetics consists of a benzene ring separated from tertiary amide either by ester or amide linkage. Based on this intermediate chain, they are classified as amino esters and amino amides. In amino esters, the local anesthesia drugs are procaine, chloroprocaine, tetracaine, benzocaine, cocaine and etc. In amino amides, the drugs are lignocaine, mepivacaine, prilocaine, bupivacaine, etiocaine, ropivacaine and etc. Next, we are going to discuss on the basis of duration of action. First, short duration, which means 15 to 30 minutes. The drugs are chloroprocaine, shortest acting local anesthetic, and the procaine. The next one is intermediate duration, which means about 30 to 90 minutes. The commonly used local anesthesia drugs in intermediate duration are lignocaine, mepivacaine, prilocaine, and cocaine. The next one is long duration, which means 2 to 3 hours. The drugs are bupivacaine, levobupivacaine, propavacaine, tetracaine, etiocane, and dibucaine. Dibucaine is the longest acting local anesthetist. Other drugs with local anesthetic properties are opioids. In opioids, the pethidine. In patients hypersensitive to local anesthetics can be given pethidine in place of local anesthetist. The next one is buprenorphine. Because of its local anesthetic properties, it is frequently used to supplement the effect of local anesthetics for nerve blocks. And the next one is tramadol. Although weak, but tramadol do not have local anesthetic properties. The next we are going to discuss about the complications of spinal anesthesia. First, the immediate complication in intraoperative or hypotension. Hypotension is the most common complication of spinal anesthesia. Mild hypotension do not occur in almost all patients, and significant hypotension may be seen in up to one-third of the patients. Mild hypertension is beneficial in reducing the blood loss. The treatment are prophylactic, although preloading with 1 to 1.5 liters of crystalloid is still practiced by many anesthesiologists, however has not been proven to prevent hypotension, therefore is no longer recommended. The another method of hypertension are curative or head-low position, which means Trendelenburg position. It is done to increase the venous return from legs and pelvic area. Head-low position of 15 to 20 degree has not been found to significantly increase the level of block. Therefore, Trendelenburg position is up to 15 to 20 degrees still remains the very vital part of management of spinal hypotension. The next one is fluids by giving crystalloids. However, if there is indication, colloids can be used safely. The next one is vasopressors. If hypotension does not respond to Trendelenburg and fluids, or if it is severe, then vasopressor should be used. As ephedrine not only proceeds vasoconstriction but also increases the cardiac output and heart rate by its beta-adrenergic properties, it is the most preferred vasopressor for the treatment of spinal hypertension. However, mefentermine is most frequently used in India. Other vasopressors which can be used are methoxamine, phenylephrine, metraminol, and epinephrine as a vasopressors of last resort. The next one is inotropes, which means dopamine and butamine. Hypotension of the spinal is because of sympathetic blockage, therefore sympathomimetic drugs are used for treatment. The inotropes only benefits indirectly by improving the cardiac output, therefore are hardly ever used. Oxygen inhalation to prevent hypoxia from hypotension. The next complication is bradycardia. Bradycardia after spinal anesthesia is quite common, incidence around 10% for the reasons already stated above. The treatment for bradycardia is intravenous atropine. Next, dyspnea, mild respiratory difficulty due to lower intercostal paralysis is treated by oxygenation and assurance. The next one is high spinal or total spinal anesthesia. High spinal is an arbitrary term. In general, high spinal means spinal above the desired level which is causing problems to the patient. However, in strict terms, high spinal refers to the level high enough to block phrenic nerve, causing diaphragmatic paralysis and apnea. If the drug reaches cranium, the involved cranial nerves, it is called as total spinal. The management depends on level of block. If it is involving only intercostals, then oxygenation and assurance may be enough. High spinal involving diaphragm and total spinal will require intubation. Severe bradycardia and hypertension seen in high spinal will require atropine and vasopressors. The next one is respiratory depression or respiratory paralysis. It is usually because of hypertension, therefore, treat hypertension and maintain positive pressure ventilation till spontaneous breathing returns. If it is because of high or total spinal, then the patient will require immediate intubation. The next one is nausea and vomiting. This is the most commonly because of hypertension causing central hypoxia. Therefore, treating oxygenation and treating hypertension should be allied to nausea and vomiting. If not, then antiemetics may be used. The next one is shivering. Shivering is one of the very common complications of spinal anesthesia, which is seen in almost half of the patients. Oxygen consumption can increase by 4 to 5 times in shivering. Therefore, the patient who is shivering must receive oxygen, and shivering should be treated by warm air, covering the patients by warm blankets, and by giving anti-shivering drugs. The drugs of choice for treatment of shivering is pethidine followed by tramadol. The next we are going to discuss about the neurological complications, which means post-dural puncture headache. It is low pressure headache due to seepage of CSF from the dural rent created by spinal needle. CSF leakage results in decreased intracranial pressure leading to traction of pain sensitive structures like dura vessels and tentorium producing pain. The CSF loss around 10 ml per hour is considered a significant loss to cause post-spinal headache. The curative method of post-spinal headache are the first line management is conservative and it includes as the patient to lie supine in slight Trendelenburg position as far as possible. The next by analgesics. The next by giving intravenous fluid, which means 15 ml per kg per hour, or oral fluids are like 3 liters per day. The aim of adequate hydration is to increase CSF production. The next oral or intravenous caffeine. 500 mg of caffeine in 1 liter of ringer lactate inhibits the vasospasm cycle in cerebral vessels. Most often headache is relieved by conservative measures. The second line drugs, which may include abdominal binders, desmopressin, inhalation of 5 to 6% CO2 in oxygen, and triptans will reduce the headache. Next, backache. Backache is mild and usually temporary. Next, nerve injury. Nerve injury, which includes all cranial nerves except 1st, 9th and 10th, can be involved after spinal anesthesia. Most commonly, 90%, 6th nerve is involved because of the longest intracranial course of 6th nerve. Causes. As a result of low CSF pressure, descent of bones and medulla can cause stretching of 6th nerve at the apex of pertoes temporal bone. The next one is transient neurological symptoms. Transient neurological symptoms, previously used called as transient radicular irritation, theoretically can occur with any local anesthetics used in clinical practice. However, most often it is seen with lignocaine. The incidence with lignocaine can be as high as 10 to 11%, which is why lignocaine is hardly used for spinal. Patients may complain of pain in buttocks radiating to legs without any neurological defect. The symptoms can resolve themselves within few days, which means within 1 week. Next, we are going to discuss about the respiratory complications of general anesthesia. The first complication is hypoxia. The common causes of hypoxemia seen in perioperative period are failure to intubate or ventilate. Failure to intubate or ventilate and not even able to ventilate is the worst nightmare for an anesthetist. A proper assessment of airway and readiness to face and handle such situations can prevent the catastrophe. The next one is pulmonary aspiration of gastric contents. Aspiration can occur any time in perioperative period Although it is not always possible to prevent aspiration, however, it is still considered as preventable complications of anesthesia. Pulmonary aspiration is one of the major causes of death associated with anesthesia. Mortality after aspiration is 5 to 70% depending on the volume and pH of aspired material and the time interval between detection and management. The next one is hypoventilation, upper airway obstruction. This may occur at incidents or in post-operative periods. The causes are tongue fall. This is due to abolition of tongue of genioglossus muscle during anesthesia. Treatment: jaw is lifted upward and forward and head is extended. The next one is oropharyngeal or nasopharyngeal airways and intubations. Secretions: blood mucus can irritate larynx producing laryngospasm and desaturations. Secretions are the most common causes of laryngospasm in anesthesia. The next one is hypoventilation. The usual cause of hypoventilation in intraoperative period is inappropriate ventilatory setting or leaks in machine and circuits, while in postoperative period the usual cause of hypoventilation is the residual effect of anesthetic agents or muscle relaxants. Pain and splints in thoracic and upper abdominal surgeries can cause significant hypoventilation. The next cardiovascular complications are hypertension, myocardial ischemia, and cardiac arrest. Hypertension. It has been observed that postoperative hypertension and tachycardia are more responsible for unplanned ICU admission and carries higher morbidity and mortality than hypotension and bradycardia. The common causes of hypertension are: in intraoperative period, the usual causes are light anesthesia, response to laryngoscopy and intubation, hypercapnia, drugs like ketamine, and undiagnosed pheochromocytoma. In post-operative period, the usual causes of hypertension are pain, hypercapnia, full bladder, and emergence of delirium. The next one is hypotension. The most common causes of hypotension in perioperative period is intravascular volume depletion, which could be because of excessive blood and fluid loss or inadequate volume replacement. Other causes may be third space fluid transfer occurs as a response to surgery and anesthesia, effect of anesthetic drugs, anesthetic techniques, cardiac events, arrhythmias, transfusion reactions, and sepsis or anaphylactic reaction. The next one is myocardial ischemia. Surgery and anesthesia are stressful conditions which can precipitate MI in susceptible individuals. The lifetime risk for reinfraction in a known patient of MI is 6%. Treatment includes oxygen, morphine, nitroglycerine, inotropes, thrombolytic therapy, and intra-aortic balloon counterpulsion. The next one is cardiac arrest. More than 80% of cardiac arrest usually occurs at the time of induction. The common causes of cardiac arrest are inability to ventilate, side effects of anesthetic agents like severe hypotension with inhalational agents or bradycardia proceeding to asystole after succinyl choline and anaphylaxis. The next one is neurological complications. The main neurological complications are convulsion, delayed recovery, and awareness. In convulsions, it may occur due to hypoxia, drugs like local anesthetics, methotrexate, enflurane, sevoflurane, and atracurium or cisatracurium. Cerebrovascular accidents. The treatment are maintain airway and anticonvulsant. The second one is delayed recovery. Delayed recovery, which means patient not regaining consciousness within 30 to 60 minutes after discontinuing anesthesia, is the most common CNS complication and is usually due to the residual effect of anesthetic agents. Most often, the patient recovers spontaneously. However, if the patient does not exhibit the signs of recovery after considerable time, he or she should be investigated for other causes for delayed recovery like electrolyte imbalance, acid-base abnormalities, metabolic abnormalities like hypoglycemia or cerebrovascular accident. And the last one is awareness, which means inadequate amnesia. Incidents are less than 1%, however, very important from medical legal point of view. Most common type is auditory. Methods to prevent awareness and recall of events are premedication with benzodiazepines produce anterograde amnesia. Inhalational agents, all inhalational agents are very good amnestic agents except nitrous oxide. Therefore, awareness usually occurs when oxygen, nitrous oxide, and opioids are used for maintenance of anesthesia. The next we are going to discuss about the gastrointestinal complications, which means post-operative nausea and vomiting. The incidence of post-operative nausea and vomiting is 20 to 30%, making it as the second most common complaint after pain in post-operative period. The risk factors of post-operative nausea and vomiting are female gender 3 times more vulnerable than males, general anesthesia. Patient given general anesthesia has 4 times more incidence of post-operative nausea and vomiting than patients who received regional anesthesia. The most common reasons may be opioids. The next one is types of surgery. Surgery like middle ear surgery, strabismus surgery, laparoscopies, and adenotonsillectomies can have higher incidence of nausea, vomiting as high as 30 to 40%. The next one is young age. The incidence of post-operative nausea and vomiting is much higher in adult as compared to old age. Next, non-smokers. For unknown reasons, non-smokers are 1.8 times more vulnerable than smokers to have post-operative nausea and vomiting. Next one is the thermal complications such as hypothermia and shivering, hyperthermia and malignant hypothermia. In hypothermia and shivering, it is the most common thermal complication seen in anesthesia. Shivering occurs as a protective mechanism to hypothermia. O2 consumption may increase to 4 times, which causes shivering. Therefore, oxygen supplementation during shivering is mandatory. Shivering can be abolished by inhibition of hypothalamus. Most commonly, shivering is seen after halothane. Treatment of shivering. Pethidine is the drug of choice. Tramadol is the second drug of choice after pethidine. Other drugs which can also be used are alpha 2 agonist, which means clonidine, dexamethasone, butyrophenol, chlorpromazine, and magnesium sulfate. Next one is hypothermia. Causes of hypothermia in anesthesia are hypermetabolic status like thoracotoxicosis and pheochromocytoma. Neuroleptic malignant syndrome due to phenothiazines. Drugs induced like atropine, pethidine, MAO inhibitors, tricyclic antidepressants, and amphetamines. Injury to hypothalamic temperature regulatory centers. And the last one is malignant hypothermia. Malignant hypothermia is the clinical syndrome associated with high mortality seen during general anesthesia, in which there is rapid rise in temperature as high as 1 degree Celsius per 5 minutes. It is due to abnormality of type 1 ryanoid receptor, which is calcium releasing channel of sacroplasmic reticulum. The abnormality leads to excessive accumulation of calcium in sacroplasmic reticulum, which causes sustained contraction of muscles. It is a genetic disease, usually autosomal dominant, but can be recessive also. Thank you.